We are going to start the infections in immunodeficiency. In immunodeficiency state, the patient or human being are so much high risk and are prone to all the infection. It is bacterial, fungal, or the viral. So first we have to start from the pathogens. When the patient, in which condition patient have a more prone, having a more risk for the bacterial infections? Yeah, obviously when the B cell the decrease in the level of the B, there will be high risk of bacterial infection. Most commonly, which bacteria? It will be encapsulated bacteria. And what are encapsulated bacteria? The bacteria that are surrounded by polysaccharide capsule. That bacteria has got encapsulated bacteria. This capsule acts as a protective layer, making them more resistant to the host immune system, specifically phagocytosis, engulfment by immune cells like macrophages. And this capsule is sometimes acts as a virus vector, meaning it increases the bacteria to ability to cause disease. And the B cell is a more dominant thing that fight against the bacterial infection. So they are one mnemonic pre-shine way skies. These pseudomonas, aeruginosa, streptococcus, pneumonia, hemophilus, influenza type B, Neisseria meningitis, Escherichia coli, Salmonella, Klebsiella, and cryptic streptococcus. And if there is a decrease in granulocytes, so which bacteria are going to cause more infection? There are some bacteria produce no serious granules. It is a mnemonic. So for S, we are having Staphylococcus, Burkholderia, Kaposia, Pseudomonas aeruginosa, Nocardia, Serratia. These are bacteria that are going to produce or cause infection when there is a decrease in granulocyte in human beings. And due to complement system, we also have an encapsulated species with the LD complement deficiencies. If you know in complement, there are two types: early complement and late complement. There is deficiency of a complement, then there will be encapsulated species infections in that human being. If there is a late complement deficiency, then most commonly there will be Neisseria recurrent infection. If we talk about the viruses, they will be in the viruses. There should be decrease in T cell because you know the CD8 positive cytotoxic cytotoxic cells are going to act against the fight against the viruses. So if there will be decrease in T cells, so there will be recurrent infection cytomegalovirus virus, Epstein-Barr virus, Ginger virus, varicella zoster virus, chronic infection with respiratory and GI viruses. B cell having no as much effect on the virus is recurrent infection, but some of viruses also cause infection in the absence of B cell, that the entire viral encephalitis, polyviral, and the patient having decreasing B cells, the lab vaccines are contraindicated. And for the fungi and the parasites, both the T cells and B cell matter. So mainly the decrease in T cell effect or cause the recurrent infection of fungi and the parasites. Candida local, it's the PCP. The PCP stand for the new pneumocystis pneumonia. It's a lung infection. Pneumocystis pneumonia, and it is caused by the fungus pneumocystis cerevisiae. So the one is cryptococcus. They are mostly happen due to decreasing T cells. Secondly, if there is a decrease in the B cells, then the high risk of recurrent infection of the GI giardiasis to the decrease in IgA, because IgA is going to produce for B cells, and also granulocytes. If they decrease the granulocyte, can be systemic candidiasis infection, aspergillus, and moxas. foreign substance. Now we'll talk about the features of good match. In good match happy same blood type and they are having same or close MSC one or two molecules. For the negative cross matching screen, the test of donor against the recipient plasma and screen for the antibodies. Like if you guys know what the mechanism, there is antigen presenting cell, that is self antigen presenting cells. They are having a self antigen. When T cells go into express them, they did not attack on that antigens because they know they belong to their own body. So when you're taking any organ or any transplant, any graft, we have to match that antigen. Self antigen should be matched from the host antigen. So same like donor and antigen present is also having the same type of antigen that the host having. Okay, because if the donor antigen is not same, for example, it is not same when the T cell is come and did not recognize and it feels like it is not belongs to its own body, then it will going to attack and destruct the donor part, destruct that part as a foreign body. The donor cells are going to express MSC class both of different from this is being then CD8 go and attack on it. MSC class 2 also express donor incapacitating cell may carry along and vascular endothelial cells may express molecular inhibitor compatibility complex 2. It is not like that we are going to match. It's not like we are going to match MSC class. We are going actually going to match actually. If you guys remember about the topic about the MSC 1 and 2, there is a one line for formation, the MSC are going to form or make up by the HLA, human leukocyte. Antigen. If different between donor and recipient, immune system will classify donor tissue as foreign. If that actually is did not match, so MSC will be not same as a human being, will not same as the host. So the CD cell may attack as a foreign on the donor tissue. The actually might think it happen as genes on chromosome 6. These are the genes that present on chromosome 6 that determine the actually type. Immunity is MSC class 1 and class 2. Should you guys remember the MSC class 1 is dependent on actually A, B, actually C, and class 2 are going to present double figures like actually DR, actually DO, DP, and DQ. Okay? And they are highly polymorphic. It is not like that they are 3 to 4 HLA. Each type, each HLA antigen, having more than 50 more than 50 subtypes important subtypes numbered like, for example, we are having HLA A. So it is having HLA A1, HLA A2, HLA A3, and so on. If the sprint did not match, then it will be go for the rejection. The HLA subtypes having some association with autoimmune diseases that you guys know, like B27, association with high risk of influencing spondylosis, and A3 having secondary hemochromatosis. Hemochromatosis. So it is in the side with HLA matching. Two sets of genes that are having the permissions and the all HLA transfer and poly from each parent. The first set from the split patient having two sets, one from mother and one from father. And therefore, if you make a chart, the sibling having 25% of chance for the perfect match. MSC matching, like this is the father. They're having F1, F2, for example. And this is the mother. They're having M1 and M2 genes. They are going to represent HLA. Okay. When if we have post section, then they will be, one combination will be like that: F1 and 1, M2, F2, M, and F2, M2. So every combination having a chance of 20%. So the 25 version of, for example, 25 F1 and M2 will be chance will be, it look like the sibling. And what will be the perfect match? The perfect having the two perfect match. The perfect match have two haplotypes. Haplotype means just some degree of compatibility and a minor histocompatibility. Antigens are there. And identical twins only time they have a two perfect match exists here taking the match only. The MSC matching are the most important in any gene for the solid organ transplant and sometimes called a 6-6 match, in which we are doing some others HLA, HLA-A, B, and E. More genes sometimes tested like HLA-C, HLA-DQ, 10 out of 10 match. The bone marrow transplant having already, I will with that, we are going for the bone marrow transplant.